Dr. Christie, thank you for your generous compliments and giving me this opportunity to be with you for about 30 minutes. Is again a lot of time. I don't know I will cover or not. And also I thank Dr. Venkatesh for giving me this opportunity. So whatever I am going to cover is already mostly covered, or the subsequent speakers will cover that. This is just a nutshell about the corneal ulcer. That is my experience. So these are the frequently encountered, commonly considered corneal blinding disease globally, even developing countries or developed countries. Like trachoma, I think 2 years back it was eliminated from India. There's no more trachoma in India. Even then, trachoma was not seen in South India. It was seen only in North India, like Rajasthan, UP, like that. Now, no trachoma. Then, this ophthalmia neonatorium was a commonest cause of childhood blindness. But I think you don't see this. After Creedy's method, that is using silver nitrate, now they use tetracycline because of the better perinatal care in India. So most of the children delivered at the hospital. So you don't see this. Then my friend, this one, keratomalacia was common, causing bilateral blindness, pediatric blindness. And now I see maybe one case in a year, not at this stage, but very early stage, and we are able to cure that. So all this blindness we don't see now. What about this? Do you see now? So many of that, my residents and fellows, I project these slides and ask them the diagnosis. Invariably, they miserably fail to diagnose this. So this was the very common cause of corneal blindness and also a fatality in India. So this was eradicated in 1975 through smallpox eradication program through WHO. So when I was in primary health center in 1974-75, I used to participate in the screening of the villages. 1,000 rupees were awarded for the public, whoever bring the patient like that. Then your duty is to rule out smallpox, the chicken pox, not smallpox like that. That also we don't see now. So these are the diseases which now prevented through vaccination or improved nutrition, all those things. This magnitude, everybody was talking about that. Now the population is going to 2 billion, and corneal ulcers range from about 7 per lakh population in developed countries, and country like Nepal, it's almost like 800. So you have plenty of corneal ulcers, and you need not go after the disease. And Aravind contribution, that apart from this. So every year, I think roughly we are adding about 7,000 corneal ulcers, 80%, 70% fungal every year. It's not, the incidence is going up in spite of all those things, all the medicines. And if you see, most of them about 70% fungal. And the Acanthamoeba in India, so in my experience, we first published in 87, Acanthamoeba non-contact lens virus from India. The incidence is same, less than 2%. We don't see much. Maybe Coimbatore, they see more patients, but Acanthamoeba and yeast fungus rare. Common pathogens causing corneal ulcer, we all agree, bacterial, fungal, parasitic, and others. Predisposing factor, we differ from developed countries. Like here, trauma is very common. It could be not severe, it's all trivial injuries, corneal abrasions. The contact lens wearer, very few. We don't see many. Ocular surface disease. Corneal surgery, no, post-op infection is less than a developed country. then some associated conditions. So commonest predisposing factor is corneal aberration. Then a little bit about history of taking care of patients with corneal ulcers. When I was a medical student and postgraduates in 70s, there was no term called fungal keratitis. They will laugh at you, professor will get upset, and they will fail you if you talk about fungal keratitis. So no term like that. Then no aminoglycosides acids, no fluoroquinolones, nothing. So only drug was, all the hospitals, pharmacy will prepare this because we can't prescribe silver nitrate, boric acid, mercurochrome, iodine. These are every day the pharmacy will prepare, they will have a beautiful table in all the government hospitals. Not much private ophthalmologists on those days. Then there is an undyne, so they drop to the patient. We can't prescribe. Every day they come, they apply. Then I don't know how many of you heard about fever therapy. Fever therapy is to induce fever and rigors so that the patient will develop more antibodies. So it's a milk injection was common. It is you collect cow's milk in the hospital, and your PG, your duty is to sterilize the milk, either boil or autoclave. So 5 ml of milk is injected intramuscular or intravenous every 2 to 3 days for 3 injections. Believing that it will induce fever and release more antibodies, more neutrophils like that, it will kill the bacteria like that. That was the therapy. And then more inpatients, 10% of the beds were occupied by corneal ulcer patients. There was no question of monotherapy or concentrated therapy, hourly drops like that. So our professor will have a loop and a torchlight, and we used to bandage the eye, remove the bandage, they will throw the torch. So apply atropine and terramycin. So only 2 drugs, oxytetracycline, terramycin and soframycin, these are the 2 drugs available on those days. Only 1 dressing, every day morning, 10 o'clock, 1 dressing. So most of them end up in perforation. No donor corneas for therapeutic graft. So evisceration was common, not uncommon. So, and the patients, they agree. They want to get relief from the pain, they don't question. The preferred practice pattern, all those things they discussed now. Then what we see here, I said, trivial injuries. Most of the patients, they come like this, 1 or 2 days duration of antistomal foreign body, mostly vegetable matter. And at the slit lamp, we remove and put it in KOH. Invariably, all the cases will have fungus. This is the vegetable foreign body. This is the fungus. And immediately you start antifungal, because these patients will have 6 vision, round people, no inflammation. But if you get this iron foreign body or rust, I remove it, I always give antibiotics. I have not seen fungal ulcer in following rust because I don't know. So when you hit the iron bar or something, it delivers the heat or something, it sterilizes that. I don't know, but I don't give antifungal, I give always antibacterial. Then now we have all the facility, microbiology, like our culture, smear, PCR, and new generation diagnostics, all those things. But still, for solo practitioners, individuals who are practicing ophthalmology, not in teaching institutes or tertiary care centers, the reliable clinical science for bacterial ulcer I have. So you'll have lydedema always, fungal you don't have, unless they have used native medicines. And the important sign is, in India, all the corneal ulcers, at least in Aravind, we syringe the lacrimal duct to look for the patency of the lacrimal pathway. So you just press here at the slit lamp and you will see this. So when you have this pus and also matted eyelashes, and there was publication from Joseph Hospital, 50% of this, they grow pneumococci. So if you have this on an ulcer, it is always pneumococcal. Treatment here, unless you remove the lacrimal sac, it won't heal. So that's the one. Then this again pneumococcal ulcer, it's called ulcus serpens, they call it, because one edge will be spreading, other edge, reeling edge will be healing. So again here, the treatment is first gram positive. They have already covered like vancomycin. Chloromenical is a drug of my choice. So unfortunately, this is banned in US. I think US, they don't use chloromenical. All other globally, all the countries, including Australia, Canada, they use chloromenical. But US, because of one case of aplastic anemia or something, they banned it. They don't use in the US. Then this kind of mucus collecting small ulcers, well-defined border, hypopyon, and again this kind of mucus. So this patient, you put him in silk tank, clean it. By the time you document all the findings, digital or paper, whatever it is, again you look, you will correct this mucus. This is my favorite clinical sign for going for Pseudomonas, gram-negative bacilli, mostly contact lens, and this also. But at the same time, you see fungal, less inflammation, and these borders you will always see in fungal ulcers. And there are papers published, Indian ophthalmologists, they are able to diagnose fungal keratitis clinically in at least 90% of the patients because they see frequently. Then these are the classical images of early fungal keratitis. Invariably, all these patients, when I see, they always already treated with acyclovir and steroids, thinking that it's a dendritic ulcer. Very difficult to differentiate. So you stain in dendrite, you will have these terminal knobs, and the floor of the ulcer, the gutter will be gray. But in fungal, the gutter will be filled by the exudate, like this, like this. So I was taught that dendritic ulcer, it gets a pattern because virus spreads along the corneal nerves. But fungal ulcer, why they get this image, I don't know. Why they get the topography like this, I don't know. This is, I strongly believe this clinical sign like this, it will mimic like dendrite, very difficult. See, they come with very, very good vision, people not involved. This is the stage you have to pick up. These ulcers, whatever it may be, fusarium or aspergillus, it heals in a week with natamycin. So this, if you don't believe, like Professor Jennifer, when she is visiting, these people, if they don't believe, I just scrape and demonstrate fungus in KOH, then they are convinced. But for me, I don't scrape these ulcers, I immediately start. Then pigmented ulcers, it's also about forms of 14% of total fungal ulcers. Easy to diagnose, you're tough. To remove this, you have to use 15 blade or something. Really, you have to cut it to remove so that drug will penetrate. So this is the third commonest cause of fungal ulcer, pigmented ulcer. Response is, finally it will respond, but it will take a lot of time. So differential diagnosis of bacterial and fungal. See this, like a butterfly, very nice. This also. But at the same time, you see bacterial, whatever may be the size, it's a well-defined border. You don't get like these fuzzy borders. And a lot of mucus for bacterial. But once it perforates, you will see the descemet's holes, and it's very difficult to diagnose clinically. Unusual clinical features. So this will, for me, it's all staphylococcal marginal keratitis. They will have blepharitis, myomitis, very bad lid hygiene. So this is typical. How it presents like this, they will have lucid interval between limbus and the lesion. So almost similar size like horizontally oval or boat shape. If you look at the other eye, they will have the previous scar. But in this case, I don't know how to diagnose because this is typically looks like soft marginal. I will use steroids. This case, I will use steroids. There are 3 corneal ulcers you can use steroids liberally. Moran's ulcer, marginal keratitis, and I forgot one more, neurotropic or something. But this one, I have to confirm with the lab diagnosis. And suture infection, post-cataplasty suture infection, mostly they grow pneumococci. They respond well. You remove the loose suture and put it in the culture plate like blood agar, and it will grow. And sometimes when you do TPK, therapeutic graft, the surgeon may not cover all those things. It is extended to sclera. It's very difficult. It could be fungal, but when it occurs, we don't know it's from same fungus or something different. So this is something you have to confirm with the lab diagnosis. Then massive hypopyon always goes in favor of fungal. But sometimes you will get massive hypopyon nocardial ulcer also. The message is this much hypopyon, whatever you do, they do ACVAS, they give intracameral antifungals, systemic antifungals, all those things. It always perforates in a week's time like that. But if you see such a massive hypopyon, if you see the ulcer size, it's not large enough, big enough to cause such a why. And even for scraping, you may not get much material. The hypopyon level also speaks for your prognosis and diagnosis. And this is Kimura spatula. I don't know how many of you using now. You don't get the standard Kimura spatula. It's all again. It is you don't get typical platinum spatula now, or not even available. You have to get from abroad. So you don't get always like this so much material to scrape, but if you have, it is well and good, then you differentiate by gram stain. KOH, unfortunately, all my friends in the US, I don't know, sorry, Jennifer, but they don't agree KOH. KOH, even now when I talk to them, they say 30% only. For us, 90% positive for not only fungus, Acanthamoeba, Nocardia. So I believe this KOH very simple. You yourself can do that. But gram stain about 80%, GAMSA about 80%, Calcofluor. But KOH gives excellent results. But many people disagree. Sometimes you will have so much pus, but you may not get anything. I don't know why. So then this she is from Kathy from San Francisco. Is a lab technician, volunteer, Seva volunteer. She helped a lot for us to diagnose Fusarium keratitis in 84. Her name was Carinius. She brought that manual of Fusarium. There was a manual of Fusarium diagnosis, the banana spores, types of Fusarium. Till that time, every time, this was the silocaine vial, we sterilize, heat sterilize, we plate the PDA. Every time it grows, nice powder like white growth. Revert side will have these pigments. Always I take it to the mycology professor at a government medical college. It's the Institute of Mycology. But they will just ignore this. They will just say it's a trichophyton. Fungus never involves the cornea. That's what they talked to me, and it was trichophyton. It's a skin infection. It's a contamination. So it took a lot of time for us to confirm the diagnosis. And medical therapy, they talked empirical, specific, topical, subconjunctival. Subconjunctival I don't give now. I was giving. So no patient will come to you for follow-up if you give subconjunctival. So painful. And especially in pediatric, all those things. So subconjunctival is good, but it's not practical, especially private practice. Then intrasomal, many of young doctors say like, now he presented 21 injections of voriconazole, fluconazole, all those things. Chinese ophthalmology, they give a lot of intracameral, but you can try if not responding to topical, intracameral. Oral, some institutes, they give oral antifungal. They do all the liver function test and routinely they give. I don't believe that unless they get endophthalmitis. Because topical, you get a lot of concentration in the cornea rather than giving orally. It's very toxic drug, costly. I don't give. Then mono and combination frequency, the other speakers may cover. But one thing I want to ask, how many of you check the drugs? If your patient, when they are coming for follow-up, how many of you check the drugs? So Jennifer, very few. So invariably, many people, illiterates, they put atropine in the antibiotic carton, and moxifloxacin and atropine carton. They apply atropine every hour and moxi 2 times a day. Then you think it's not responding. So important thing is your job, primary job is just to, instead of talking too much about that. If you ask a corneal ulcer patient, how are you? They will say, oh, I am fine. They will never say that. Always they will have severe pain, vision is dark like. Instead of that, check the medicines. And that is very important, whether it is monotherapy, concentrated, all those things. So this that I was talking, Pseudomonas, college student, weekend they went for a college tour. 3 days he didn't remove the contact lens. And this, I know without scraping, I know it was Pseudomonas, monotherapy. I started Vigamax. And usually, we are sometimes bookish. We say antibiotic fight every minute for 5 minutes, every 5 minutes for 15 minutes, every 15 minutes for 1 hour. Like, who will apply this? So waking hours, we just say hourly. I don't know how often they apply, we don't know. And you just insist at least hourly waking hours, not during sleep. I don't disturb. They hardly sleep with the pain. So I never disturb, whatever may be the answer, you sleep. So this healed in with Vigamax, 1 week completely healed. Then even Pseudomonas, I am not worried about. Whatever may be the size of the ulcer, it really responds. Maybe they are leaving a scar, but fungal this size will perforate. And this is the one case, Pseudomonas, you have sterilized the ulcer, still the hypopyon is lurking. Then here I use steroids, maybe 4 times a day for a week like that. Then hypopyon disappears. The steroid delays the epithelial healing. See, some way it is other way, so it promotes epithelial healing in Pseudomonas ulcers. So I don't use very often. We did the SCUT study, but Pseudomonas, large ulcers, central ulcers, if inflammation persists, then this is my friend Nocardia. Why they get this shape? Ring of pearls, like necklace. So this is the confirmatory diagnosis. Culture will slow growing. You will have golden orange color, but it's a rough colonies. Gram stain helps you. Lot of mycelia. You don't get actinomyces, you get mostly nocardia. And trimethoprim is drug of choice. We don't get it now. So I start either sulfacetamide 20% or amikacin 2%, and it really responds. Again, this nocardia, I said this dots very important. So even so much hypopyon, it nicely healed with monotherapy, amikacin. So medical therapy, fungal, you have topical and newer antifungal, I have not tried. So natamycin is there. So nobody is replacing that. 60 years it is there. This is only FDA approved antifungal. But nobody is interested. They say there is no market for that. So all the pharmacy, they are interested in artificial tears and anti-glaucoma drugs. It has a lot of market. Unfortunately, you don't have. Voriconazole, we did the study. It doesn't help for the filamentous fungi. So still my drug of choice is natamycin. Then sometimes I give amphotericin B, it is aspergillus. And aspergillus amphotericin B is more toxic, you get necrosis. You give subcongenital, will produce congenital necrosis. So, but if you get aspergillus not responding to natamycin or econazole, then you can try amphotericin B, and there are so many, I think, formulations available. You should mix it. It easily contaminates with Pseudomonas. So this is one of our much study case, diagnosed with natamycin monotherapy, topical, nicely healed. Can we prevent fungal keratitis? I don't believe so. You can't do this. The fusarium is everywhere, all the plants, banana, guava, coconut, peanut. And in India, this is the one onion. So when the patient comes with a corneal ulcer, if it's a farmer, you just ask them what were you doing 2 days earlier. You have to put the question because they never thought it will be correlated. So any injury with a branch of tree or something, cow horn, whatever it is, they will mention. But onion, they think it is not related to corneal ulcer. So you put this question, if they say they were harvesting onion or loading in a market, onion market, loading in a truck, unloading, all those things, always fusarium. And Acanthamoeba, you had nice talk. This radial catoneuritis, we don't see much. Maybe in contact lens variants we see, but in India, it's only 2% of patients will have. So constant thing is mid-periphery, this stromal ring, constant thing. Sometimes you may get some bizarre clinical features like vertical hypopyon. So this you have to confirm. Clinically, you can confirm, but better to do the Gram-Strain, GAMSA. If you have confocal, you can do that. Culture also. Then my friend, this Pythium is now not a problem for us, and India is not rare. I think it's not new. I think we missed this as unidentified hyaline fungi. 30% of our lab report unidentified hyaline fungi, it must be Pythium. So these are the horses. The British soldiers in India, Indonesia, all those places, they had the cavalry horses. They clean the horse in a swamp of water. They found, sorry, animals, mostly horses, cattle, dogs, all those get Pythium. It was a disease of animals. We are also animals, so we are also getting now. So only 2 species we get. And clinical diagnosis is, I think it's relatively simple. You can make it typical tentacles here. And the color will be mostly a little bit silvery white. You have gutter, ridges. And this one you will see in a dilated people, if you retroillumination, you can nicely see the stromal mycelia. This is characteristic of Pythium keratitis, is the tentacles also. Then your stain calcofluor. And Pythium grows very well in blood agar in 48 hours, not in PDA. So if you have doubt, ask the patient to come after 2 days. It grows in blood agar, then it confirms your diagnosis. And this is KOH. The mycelia will be uneven, like a tubes, very few septae. Calcofluor white helps very nicely. So this lab diagnosis will confirm. Clinically also, but you have to confirm this lab diagnosis. Treatment, a different way of treating the Pythium patients. In our own hospital, we have different. Many people, they use linezolid, then they use azithromycin, all those things. But I use only itraconazole. This is 16-year-old student, got Pythium, confirmed, grow in blood agar, 3 weeks, itraconazole topical, nicely heals. I don't give linezolid. It's very toxic, powerful. I don't know how the science favors linezolid in Pythium. Linezolid is a powerful antibiotic against pneumococci, very toxic drug. How it will work for this pro-fungus, I don't know. But many people are using now. And this is another case of Pythium keratitis. Actually, this patient was posted for therapeutic graft, and I cancelled and I treated with itraconazole and it healed well. So this is the one case, interesting. I watched 2 minutes I have. This patient, it took about 5 months to clinic the diagnosis. This lady lives in Gulf countries, she is from Kerala. Whenever she comes to Kerala, she gets the symptoms. The baseline was 2 millimeter corneal scar, treated as stromal viral keratitis, topical steroid, and she developed steroid-induced glaucoma. Then our UVA clinic, they did PCR for all the virus, PCR for fungus, and all the bacteriological investigation. Everything was negative. When I saw the patient, it was like this. So then I told my colleague, so there's a lot of material, pulsing material, why don't you try again scraping and see that? And to our surprise, it was Microsporidia. So Microsporidium, keratoconjunctivitis, we get every day now. 3 or 4 patients, whole family. It mimics exactly like EKC, epidemic keratoconjunctivitis due to adenovirus, but it's mostly Microsporidium. So ulcer you get in immunocompromised patients. Keratitis, conjunctivitis you get immunocompetent. So this, unfortunately, we missed this when we did TPK, and but pathology didn't confirm that. But we got all the smears positive. This is one of the cases of stromal keratitis mimicking as a rejection, corneal rejection, or a lot of steroids. And when we did regraft, it's a keratoconus young lady, you could get a lot of Microsporidia. This keratoconjunctivitis is easy to diagnose. Severe congestion, chemosis, membrane formation, lid edema, all those things. Then stuck-on appearance. You just scrape this and see that you will see the spores. This fungus. It's not parasite, it's a fungus. So you can see this. These are the Microsporidial keratitis. Doesn't respond, but you get in, you have to rule out immunocompromised patient. Then this is what I use it. I use only topical fluconazole or the keratoconjunctivitis also for corneal ulcer. I use only this. Sometimes some people use oral fluconazole also. Then this from Ames, they have recently reported fungus against Pseudosporium. This we have seen several years back. Prognosis bad, but this is not as common as Fusarium. The last slide, and a kid like this having bilateral corneal ulcer, looking at the bright light, they love the light, they know blepharospasm, nothing is there, no chemosis. This is the one you have to think about, congenital corneal anesthesia. The bilateral is scrape, sometimes you get, sometimes you don't get anything. Unfortunately, we don't have any treatment. I think Anita, these people, they are trying neurotization. I don't know how far it's going to help, but I do just central tarsorrhaphy. Unfortunate, it's problem, you can't release the tarsorrhaphy. So this is rare, it's not common. So the conclusion, I feel role of general ophthalmologist has a lot of significance in preventing corneal blindness in India. Thank you.